Good morning, all. Welcome back to Kent Academics, that is Karnataka ENT Hospital Academic Program, Otology seminars. Today we have the topic Endoscopic Anatomy of the Middle Ear, and the speaker is Dr. Vasudha Singh, our Otology Fellow, as well as Junior Consultant of Karnataka ENT Hospital, Chitradurga. Yeah, thank you, Ma. You can start your presentation.
Okay, sir. Good morning, everyone. Today I'll be presenting on the endoscopic anatomy of middle ear. My presentation will be under the following headings: introduction of the endoscopic endoscopes and endoscopic ear surgeries, a brief history about it, the compartments of middle ear in terms of endoscopic view, and the important middle ear contents. So the question arises why there was a need for endoscope in ear surgeries when the microscope was giving us very good visualization, magnification, and results as well. It's because with time, experienced otosurgeons has felt the need to develop different techniques for exploring the complex anatomical spaces of the middle ear that are difficult to visualize with microscope, and thus it leads to some residual diseases leading to recurrences. And also the view which is offered by the microscope is kind of a straight line view. Thus, we don't get to see or look around the corners. And thus it also is a challenging thing for a microscopic ear surgery. And so a lot of spaces or recesses tends to harbor the diseases despite of our good efforts in clearing them. And the view is also restricted or limited depending upon the canal, like canal bulge, being the cartilaginous or the bony. So for these all things, the endoscope has given us good aid along with the microscopes. So as I said, the microscope in this left picture, you can see the vision which is provided is the limited and a straight line vision. And it also gets hampered when there is a narrowing in the ear canal. Whereas, so in order to overcome it, we have done means all the experienced otosurgeons are adopting most of the time the post-auricular axis for a wider exposure and better clearance, and it is giving us good results also. But the transcanal is kind of complicated because of the axis, the narrowing part of the canal. But if we use an endoscope for certain areas, so we need not have to struggle with the narrowing part as well as the wider vision and the corner, the looking around the corners, the hidden recesses, they all will be covered. So this is the benefits of the endoscope, which we can use along with the microscopic ear surgeries. So let's discuss how the history of this endoscopic ear surgery started. First, it started in 1982, first for the endoscopic purposes through the trans-tympanic approach by Nomura and Takahashi. Later, the true beginning of the surgery with the help of endoscope was for the second look mastoidectomies. And for the second look inspection of the mastoid cavities, endoscope was also used by McKenna. So in the late 90s, the endoscope was gradually adopted for the second look surgeries, and later it became as a part of the first surgeries or along with the microscopic ear surgeries. A famous professors in the ENT, that Daniel Marchioni and Livio Prussak'S, in 2009, they described a very important space or a ventilation pathway, that is the epitympanic isthmus between the cochleaform process and the IS joint, which is responsible for the ventilation of the attic part, the anterior attic. And sometimes the disease gets to, means it remains even after despite efforts with the microscopic ear surgeries. So endoscope helped really in these type of recesses, which we'll discuss in the coming slides. So let's start with the compartments of middle ear. So we know the middle ear compartments, there are 5, and the major compartment, the central compartment, the biggest one is the mesotympanum, and it is continued posteriorly to the retrotympanum, anteriorly to the protympanum, inferiorly to the hypotympanum, and the superior limit is actually kind of a barrier. There's a barrier called as a diaphragm, epitympanic diaphragm, between the epitympanum and the mesotympanum. So let's study the endoscopic anatomy of each of these middle ear compartments. First, starting the posterior compartment. that is the retrotympanum. So this is the left ear of the patient, middle ear. Okay, so I'll start again from the middle ear compartments.
Okay.
Sorry, because of the network issues, I got disconnected. The middle ear compartments, as I said, there are 5, and we'll discuss in terms of the mesotympanum. So the mesotympanum, the central and the biggest compartment, is having communication anteriorly to the protympanum, inferiorly to the hypotympanum, posteriorly to the retrotympanum, and superiorly the attic or the epitympanum. The communication is only through a small opening, and majorly there is a diaphragm or epitympanic barrier which prevents communication between the mesotympanum and the epitympanum. So let's study one by one each compartment endoscopic anatomy. So this is a left ear of the patient, and we are going to study the retrotympanum part of the middle ear. So this is the central part, the mesotympanum, and the part in relation to the posterior aspect of the mesotympanum is the retrotympanum. So this is the retrotympanum part of the middle ear, and it extends from the, we can say superior extent from the facial nerve, beneath the facial nerve till the funiculus, a bridge of bone in the inferior retrotympanum. We'll study in detail each structure. So this retrotympanum, it is divided by a bony bridge into 2 parts, a superior part and an inferior part. So in this picture, we can see this is a mesotympanum. This is the posterior part, the retrotympanum. This is the superior part, which is above the subiculum, the superior retrotympanum, and the part which is below the subiculum is the inferior retrotympanum. If we see in an endoscopic view, this is the right ear of the patient, and in this right ear, this is the retrotympanum part, in which we can see this is the subiculum, and the part which is above the subiculum is the superior retrotympanum, and the part which is below this is the inferior retrotympanum. This will be funiculus. So this is the retrotympanum. Let's study in detail. A very important structure or a bony prominence in the retrotympanum is the pyramidal eminence. It is present in the superior retrotympanum, and it gives rise to various bony ridges, and it divides, or it separates a lot of spaces in the retrotympanum which can harbor the diseases. So this is also considered as the fulcrum of the retrotympanum, the superior retrotympanum. It gives origin to it gives some bony prominences anteriorly towards the promontory, which is called as the ponticulus, and posteriorly towards the caudal eminence, which is called as the caudal ridge. So with the ponticulus, it separates the spaces which lies medial to the facial nerve, the mastoid segment of the facial nerve. And these spaces, it separates superiorly the posterior tympanic space, inferiorly the sinus tympani. And the lateral spaces are separated by the caudal ridge. We can say vertical partition, and the horizontal partition is the ponticulus towards the promontory and the caudal ridge towards the caudal eminence. So there are 4 spaces. 2 spaces are medial spaces, 2 are the lateral spaces. Medial spaces are termed as posterior tympanic sinus, superiorly to the ponticulus. Inferior to the ponticulus is the sinus tympani. And the lateral sinuses or the lateral spaces of the superior retrotympanum includes the facial recess, which is superior to the caudal ridge, and the lateral tympanic sinus, which is inferior to the caudal ridge. In an endoscopic view, let's see. So this is the right ear of the patient. We are seeing the retrotympanum part, and this is the subiculum. So this is the superior retrotympanum, and there are 4 spaces. This is the facial nerve, and this is the facial nerve. This is the facial nerve and the pyramidal eminence. With respect to it, these 2 are the medial spaces, that is the posterior tympanic sinus and the sinus tympani, and these 2, which are lateral to the facial nerve and the pyramidal eminence, are the lateral spaces, facial recess and lateral tympanic sinus. Let's discuss one by one in detail. The medial spaces first. So the medial spaces, as I said, posterior tympanic sinus and the sinus tympani. You can see in the left ear of the patient, this is the posterior tympanic sinus, and this is the sinus tympani, separated by a bony bridge, that is the ponticulus, which is arising from the pyramidal eminence towards the promontory. Similarly, in the right ear of the patient, You can see the posterior tympanic sinus and the sinus tympani. Let's study each sinus in detail. Each space in detail, I mean. Sinus tympani, this is the important space for the residual diseases, and it is limited superiorly by the ponticulus, inferiorly by the subiculum. The one is the marked structure, one is the ponticulus, this is the subiculum, and it is limited medially by the posterior semicircular canal and the vestibule, and laterally, and also it is limited to the pyramidal eminence, and it harbors the diseases for the like which can lead to recurrences in future. There are various depths of the sinus tympani and shape and depths which can cause the disease to permanently stay there. So on the basis of shape, it is classified into a few types, like classical shape, which is a normal partition which is divided from the ponticulus and subiculum, and normal sinus tympani. And when this subiculum, the superior partition, that is the ponticulus, is absent, or it is very fine membrane is there kind of, then it is confluent with the posterior tympanic sinus, the superior sinus of the medial space. So it is called as the confluent shape of the sinus tympani. Sometimes there is a bony bridge from the facial nerve towards the promontory in between the sinus tympani, and thus it is called as it is divided further into superior sinus tympani and inferior sinus tympani. And along with that, another shape of sinus tympani, which is called as restricted shape, it can be due to the higher jugular bulb from the hypotympanum, which is restricting the sinus tympani. So it is called as restricted shape of the sinus tympani. Sinus tympani is also classified on the basis of depth. And there are three types: A, B, C. The A is called as the small sinus tympani, B, the deep sinus tympani, and the very deep sinus tympani with posterior extension is termed as type C. So in type A, the sinus tympani, the medial limit of the sinus tympani, doesn't cross the medial edge or the medial border of the facial nerve. So the disease clearance is very easy. Even with the microscopic approaches, we can clear. Endoscope will also help, definitely. In type B type of sinuses, which are deep sinuses, the sinus tympani it extends medially along the medial border of the facial nerve, but it doesn't go posteriorly beyond. So this type of sinus tympani is difficult to be cleared from the disease with the help of microscope, and hence the endoscope gives a better clearance for this type of sinus tympani disease clearance. In type C, which is very deep sinus tympani, which is crossing the medial aspect and going posteriorly to the facial nerve, these type of sinus tympani are very difficult to clear even with the help of endoscopes. So it has been suggested that we can use retrofacial approaches from the mastoid and can clear the disease if we see a type C or a very deep sinus tympani. Okay, another structure in the retrotympanum, superior retrotympanum, is the ponticulus, which we have studied. It is extending from the pyramidal eminence towards the promontory and dividing the medial spaces into the posterior tympanic sinus superiorly and the sinus tympani inferiorly. Similarly, in the left ear as well, you can see here, this is the ponticulus. The ponticulus also has a various variants, which can also lead to extension of the spaces and disease clearance. So if you talk about the classical ponticulus, then it's a partition which we studied from the pyramidal eminence to the promontory, which is dividing the spaces. And knowing the anatomy, we can clear the diseases from these spaces, the medial spaces. But sometimes the ponticulus is incomplete, and it can lead to the continuation of the sinus tympani to the posterior tympanic sinus. So we need to clear so we need to know the ponticulus variant so that we can clear the disease if we find the disease intraoperatively in the sinus tympani. And sometimes there is a fine bridge of the ponticulus, and it also leads to communicating disease from the sinus tympani towards the posterior tympanic sinus. So it becomes tricky, but we have to find out the variant if possible, whenever possible, which is mainly helped with the help of endoscope, and try to clear the disease to avoid any recurrences. This is the endoscopic picture of the bridge ponticulus or the communicating ponticulus. And you can see the disease is continuing between the two spaces, if present, I mean. So let's discuss another structure in the retrotympanum, which I told as the fulcrum, the pyramidal eminence. So this pyramidal eminence, it divides the spaces and also the medial spaces into two parts when it gives a bony bridge, the ponticulus, and also it harbors a space within itself, means beneath it, depending upon the pneumatization of the retrotympanum. If the retrotympanum is well pneumatized, there are a lot of spaces, then there is a recess beneath the pyramidal eminence also, that is the subpyramidal space. And this subpyramidal space, if you see in this left ear of the patient, sorry, right ear of the patient, then you can see the communication superiorly to the posterior tympanic sinus and inferiorly to the sinus tympani. So the pyramidal eminence variant, if possible, we have to look for that also. So in this picture, you can see if the sinus tympani, this is the pyramidal eminence, not very well pneumatized. So this is the space which can be seen, the dotted structure, which can be seen beneath the pyramidal eminence, and the disease can extend from both these sinuses towards this subpyramidal space. When it is well pneumatized space beneath this pyramidal eminence, then the space also becomes big, and we have to go look for the disease in that space also. So there are various morphology, like it can be merged with the medial wall. So there will be no space, subpyramidal space, and only we have to look for the disease in these two spaces if it's there. And sometimes it's a partial pneumatization or a mild pneumatization of the retrotympanum leading to a triangular space. And thus we have to clear the disease, and it forms a deep subpyramidal space morphology. Sometimes there is a very deep subpyramidal space because of the extensive pneumatization of the retrotympanum beneath the pyramidal eminence. So this can be a pathology, this can be a subpyramidal space morphology which we should be aware of. Okay, now the subiculum, another structure in the retrotympanum, which divides actually the superior retrotympanum from the inferior retrotympanum, and it extends from the styloid eminence towards the promontory. And it is attached actually towards the it is attached to the round window, the posterior lip of the round window niche, and it divides the sinus tympani, especially from the inferior retrotympanum, or the sinus which is present in the inferior retrotympanum, that is sinus subtympanicus. And this is the left ear, right ear of the patient. In the left ear also you can see the same picture. This is the subiculum, which is dividing the superior and the inferior retrotympanum. There is a various morphology of subiculum also, like a complete subiculum. It separates the two spaces, superior and the inferior retrotympanum, but sometimes it is absent, then it will be confluent. So we have to be looking the disease if found in the sinus tympani. Also we have to look in the sinus subtympanicus. And many times a bridge of bone is present, so there is a communication beneath it. So that also requires clearance depending upon the situation. So that was all about the superior retrotympanum. Let's discuss the inferior retrotympanum. So the inferior retrotympanum, that means the part which is present below the subiculum. So this retrotympanum has, if you say about the boundaries, it will be superiorly subiculum, inferiorly funiculus, posteriorly will be the styloid complex and the facial nerve, and anteriorly will be the round window niche and the tegmen of the round window niche, the pillars of the round window niche, posterior and the anterior, and the sinus which is present in the retrotympanum, inferior retrotympanum, is the sinus subtympanicus. So I've been saying these terms, funiculus and fustus, many times. Let's discuss what are these. These are nothing but the bony bridges which is present in the inferior. This is the inferior limit of the retrotympanum. We can say funiculus, which is from the inferior retrotympanum towards the promontory, or we can say towards the anterior pillar of the round window niche, and it demarcates or separates the retrotympanum from the hypotympanum. Whereas fustus is a bony column which is forming the floor of the round window niche, and it's a part of the sinus subtympanicus. You can see in the endoscopic picture also, on the left ear of the patient, this is the fustus towards the round window niche. The funiculus is also having a lot of variations in the morphology, like it's a complete or a ridge. The hypotympanum, and there can be absent funiculus also. So let's discuss the sinus subtympanicus. In the inferior retrotympanum, a space which is limited superiorly by the subiculum, inferiorly by the funiculus, anteriorly by the round window niche, and posteriorly by the styloid eminence. And depending upon the morphology or disease or the variants of the subiculum funiculus, we have to look for the disease clearance in the sinus subtympanicus as well. Okay, so this was all about retrotympanum. Let's start our discussion about the epitympanum or the attic part. Before discussing the epitympanum, I would like to discuss a demarcation or diaphragm which is present between the epitympanum and the mesotympanum, because it's not like other compartments are in continuity with each other. The epitympanum or the attic doesn't show any such thing. So let's discuss a diaphragm which is separating the attic from the mesotympanum compartment, which is the epitympanic diaphragm. We all know that the attic is divided by a small imaginary horizontal line from the lateral process of the malleus. So the part above is the attic and the below part is the mesotympanum. And this attic part is further divided by the diaphragm, the epitympanic diaphragm, formed by various structures, which we'll study in the coming slide, into the two units, upper unit and the lower unit. If we see endoscopic picture, then in this endoscopic picture, you can see this is a part of various folds which are forming the epitympanic diaphragm, and it will divide the upper part, the attic. The attic, it will divide into two parts, the upper unit and the lower unit. The lower unit is mainly contributed by the PRUSSAK'S space, which will be around here near the neck of the malleus, and the other parts have a lot of spaces in the upper unit, which we'll discuss in the coming slides. So what is mainly the content of the epitympanic diaphragm, which is causing the attic to be partitioned from the mesotympanum? So it is formed by a lot of structures like bones, the malleus, the head of the malleus, the incus body, short process, and various folds like anteriorly. If we look, then the anterior malleal ligamental fold, anterior malleal ligament, anterior malleal ligamental fold, lateral malleal fold, lateral incudomalleal fold, and posteriorly will be the posterior incudal fold. On the medial aspect, there will be a tensor tympani fold. So this epitympanic diaphragm, this is the superior view which we are seeing of a middle ear of the attic part, and this will have a communication posteriorly to the adytus or the antrum part. So there is no communication, barely any communication from the epitympanic diaphragm to the mesotympanum, only except small openings, millimeter size openings, which we'll study. What are these in the coming slides? So this is the diaphragm. If we see an endoscopic picture of this epitympanic diaphragm, so this is the right middle ear. So, hello, sir, am I audible, sir?
Yes, ma'am. Go ahead. Yeah.
So, sir, from epitympanic diaphragm, I'll start again, sir. I think.
Yeah, you should start again. Huh?
Okay, sir.
Yeah.
Okay. Right,
we have a couple of questions. We'll take it at the end of this presentation. Yeah.
Okay. So epitympanic diaphragm I was discussing. So this is a partition which is present between the mesotympanum and the attic, and it divides the attic into two units, the upper unit and the lower unit. The lower unit is mainly the PRUSSAK'S space, which is here around the neck of the malleus, and the upper attic, which has a lot of spaces, which we'll study in the coming slides. If we see the endoscopic. Okay. So this is a picture of the superior view of the right middle ear, which we are seeing. This is the anterior aspect, this is the posterior, the lateral, and the medial aspect. And in this, we are trying to show the epitympanic diaphragm. So this epitympanic diaphragm is formed mainly by the two major bones, that is the malleus head, the incus body, and the short process of the incus, and various ligaments and folds like anterior malleal ligament anteriorly, anterior malleal ligamental fold on the lateral aspect, lateral malleal fold, lateral incudomalleal fold on the lateral aspect, posteriorly the posterior inguinal ligament, and on the medial aspect, the tensor tympani fold and the tensor tympani muscle. This epitympanic diaphragm has small openings which will allow the ventilation of the attic, which we'll discuss in the coming slides. And these openings can also get blocked or occupied with various granulations or diseased mucosa, leading to attic pathologies, especially the anterior attic pathologies, so which we have to be aware of. And two, we should clear these ventilation pathways every time when we are addressing a pathology in the attic. And this all ventilation of the attic will be continuous posteriorly through the adductors to the antrum and the mastoid. So let's see the endoscopic picture, the superior view of the right middle ear, showing the epitympanic diaphragm formed by the malleus head, the incus body, short process, various folds like anterior malleal fold and the ligament anteriorly, laterally the lateral malleal lateral malleal fold, then the incudo-malleal ligamental fold. Posteriorly will be the two posterior incudal ligaments. And on the medial aspect, there will be the tensor tympani fold and the tendon. And these are the this is the stapes, and these are the openings in the epitympanic diaphragm, which we'll study in the coming slides. So the ventilation of the attic is through these millimeter size openings, which are termed as isthmus. And this is responsible for it is divided into two parts. And it is present mainly in the middle part of the attic, which we can see in this picture. And there are two, the isthmus or the opening, the anterior one, which is the main contributory opening, which is around 1 to 3 millimeters, and a posterior one. And these two are separated by the medial incudal fold. An additional opening you can see here in the anterior aspect, which is the tensor tympani fold, which is most of the time not present. Only around 20 to 25% of the patient, they have a defect, and it helps actually for the ventilation of the attic directly from the protympanum, that is from the supratubal recess of the protympanum. They get an additional ventilation pathway of the attic. In the endoscopic picture of the right middle ear superior view, you can see these isthmuses clearly. This is the anterior isthmus and this is the posterior isthmus. And this further cause ventilation of the attic and to the adductors and the antrum posteriorly. Now let's discuss all the spaces of the attic in detail. The upper unit of the attic, as I told, is above the level of the epitympanic diaphragm. So we can imagine there are a lot of spaces here, which is forming the upper unit of the attic. And this is the endoscopic picture of the same in the lateral view, and with the part of the sputum removed, and you can see various folds like the lateral malleal fold, the incudo-malleal ligamental fold, the lateral aspects of this fold, which is dividing the attic into various spaces. Let's study one by one. So first we'll study one fold which is dividing the attic into two compartments. That is a fold in the coronal plane, the superior malleal fold, which divides the attic into a small anterior compartment, the anterior attic, and a large posterior compartment, the posterior attic. And we can see in the endoscopic view as well, the same thing. This is the head of the malleus. And in this, you can see, you can appreciate might be that there is a small fold on the coronal, in a coronal plane, which is the superior malleal fold, which divides the attic, the upper unit of the attic, into anterior and the posterior spaces. The posterior being the large, the anterior being the small. So let's start with the larger space, that is the posterior attic or the posterior epitympanic space. It is mainly contributed by the posterior part of the head of the malleus, a part of the body, and the short process of the incus. And it also has a fold in a superior direction, but in the sagittal plane, which divides this posterior attic again into various spaces. The major being the medial attic and the lateral attic. The lateral attic is again further divided by this lateral incudo-malleal fold, the pinkish kind of fold which you can see, into the upper part and the lower part, which we'll see in the coming slides. So this is the posterior epitympanic space, the endoscopic view. And when there is a fold, which is not visible in this picture, when there is a fold on the superior aspect of this posterior of the incus body, that is the superior incudal fold, it will divide the posterior attic into various spaces. So we can see these are the spaces which will be present laterally. Actually, these are the lateral malleal fold, incudomalleal ligamental fold. So these two folds, they are forming the lateral posterior attic spaces, and the spaces which are present medial to this, if you can imagine medial to this, will be the medial attic space. And this space will be further divided into superior and inferior by this. So the part which will be above this will be the posterior attic lateral part, but the superior one, and the part which will be below this will be the lateral part of the posterior attic, inferior one. We'll discuss in the coming slides. So let's see this endoscopic picture. You can see that the part of the scutum is removed here, and the lateral incudomalleal fold, which is also removed, but you can see a faint line and the marking here, and the lateral malleal fold. So this was the lateral attachment of these two folds, which was dividing the lateral attic into the superior lateral and the inferior lateral. And medial to this was the medial attic, depending upon the orientation of the superior incudal fold, which cannot be seen here, but you can say this was the medial attic and this is the lateral attic. This medial and the lateral attic are also termed depending upon the areas. Like medial attic is also called as the medial incudal space, and so let's study the medial incudal space, which is present in the medial part related to the medial aspect by the facial nerve and the lateral semicircular canal, and laterally it is related to the incus body and the short process, and it is kind of in the continuation with the isthmus and the mesotympanum. So medial attic gets ventilation from this. The isthmus lies in this area of the medial attic. And now let's see the lateral posterior part of the attic, which is this part, a smaller part, and it is again divided into superior and inferior by these folds, which I said. And these folds are also the lateral attic is further divided into small spaces, depending upon the presence of the space over which they are lying. Like the space of the lateral posterior attic, which is lying over the lateral malleal fold, is called as lateral malleal space, and the space of the lateral attic, which is lying over the lateral incudomalleal fold, is called as the superior incudal space. Let's see in this picture. So this was the fold attaching to the lateral wall, which is removed, dividing into superior and inferior part. So the part which will be above the lateral malleal fold will be the lateral malleal space, and above this will be the superior incudal space. And below this, the inferior lateral attic, which we'll study in the coming slides. So we have studied the upper lateral attic and the spaces. Let's see the endoscopic picture. So as I said, these are the folds which are present. Above these folds, the spaces are termed like this is a part of the lateral attic, superior lateral attic, and this is the lateral malleal space and the superior incudal space. And the part which is present below these two folds is the inferior lateral attic. And this inferior lateral attic is also called as inferior incudal space. Okay. So this was all about the posterior attic, which we studied in the previous slides. Now let's study the small anterior partition by the superior malleal fold, that is the anterior attic, which is visualized in this picture. So this is a small part, this is a small space, and it is further divided by a bone, a cog, into two spaces, which we will study in the coming slides. So this space, the anterior epitympanum or the anterior attic, is divided by a bony bridge, which is coming from the tegmen tympani, extending downwards in an inferior direction, and dividing this anterior attic into two parts, into two spaces. That is, a larger anterior space anterior to the cog is the anterior epitympanic space, and a smaller space which is behind the cog but in front of the head of the malleus is anterior malleal space. And these spaces, they are separated from the protympanum by the tensor tympani fold, which you can see clearly in this picture. That's why the attic doesn't get ventilation most of the time, because the fold is complete. let's study a few things about the cog, which was seen in the anterior attic. So it is present in the anterior attic. If we remove the ossicles, we can see this bony ridge which is coming from the tegment tympani in inferior direction, and it is giving attachments to it's giving attachment to the this fold, which is very important, the tensor tympani fold, and also it also act as a important landmark for the geniculate ganglion also. So this cog has to be identified, and sometimes for clearing the diseases from the anterior attic, we have to drill this cog, and we have to open up the tensor tympani fold also if we suspect any pathology in the anterior attic or the anterior epitympanum space. So that was all about the upper unit of the attic. Lower unit of the attic is mainly contributed by the PRUSSAK'S space. We all know this PRUSSAK'S space is around the neck of the malleus, and it is formed by in between the pars flaccida part of the tympanic membrane and the neck of the malleus. If we remove all this tegment and the attic wall, outer attic wall, we can see this is a lower unit of attic, that is the pars flaccida we are referring here, and this is limited anteriorly by the anterior malleal fold, superiorly by the lateral malleal fold, and we know the floor is formed by the neck of the malleus and laterally by the pars flaccida, but there is no communication between the upper unit and the lower unit because there is epitympanic diaphragm is there. Okay, so the ventilation of the upper unit doesn't happen from the PRUSSAK'S space. PRUSSAK'S space has its separate ventilation, which will be through a separate pouch in the mesotympanum, which is called as the posterior pouch of von Trosch, which ventilates this the PRUSSAK'S space, which we'll study later. So this was all about the second compartment, that is the epitympanum. Now the third compartment, the protympanum. The part of the middle ear compartment which is present anterior in reference to the mesotympanum. So this is the mesotympanum, this is the protympanum, and the protympanum, let's study the relations of the protympanum. It is related anteriorly and medial to the carotid canal, and superiorly will be the bony canal for the semi-bony canal for the tensor tympani tendon, and there is an extension in the extension superiorly of the protympanum, that is the supratubal recess. And okay, we have also the two spaces or the two openings in the protympanum, that is the eustachian tube opening inferiorly and the superior extent and superior space or recess, which is the supratubal recess. Let's discuss these two important spaces of the protympanum. So supratubal recess, it's a space which is present above the eustachian tube opening and the tensor tympani fold below the tegment, and this prevents any communication. This supratubal recess and the tensor tympani fold, they prevent any communication to the anterior attic or ventilation of the anterior attic. So to know about this, we should know the tensor tympani fold also. Tensor tympani fold, it's an oblique fold which is having two parts, a vertical part and a horizontal part, and this part, they are having attachments from medial to lateral aspect if we consider along the bony canal of the tensor tympani tendon, and also it is attaching to this cog bone. You can see this tensor tympani, it is attaching to this bone which is cog. So for a clearance of the disease, sometimes on the anterior attic, we have to open the tensor tympani fold as well as to drill out the anterior attic. Drill out the cog, I mean. So this is because of the attachment and because of the complete closure of the supratubal recess of the protympanum from the anterior epitympanum. There are various supratubal recess morphology depending upon the angulation of the tensor tympani fold. If the tensor tympani fold is angulated vertically or almost vertically and attaching posteriorly to the cochleoform process and superiorly to the cog, which I said, then there will be a significant supratubal recess. And in cases of, or a wide supratubal recess, we can say, and cases of a horizontal or more flattened kind of attachment of the tensor tympani fold, there will be a narrow supratubal recess, and sometimes there can be absent supratubal recess also. Let's study the hypotympanum. The hypotympanum part is a part of the middle ear compartment, which is lying below the level of the annulus, and it is composed of various irregular shaped bones, cells actually, and it is contributed by both the tympanic bone and the petrous bone in an inferior medial direction. It is, if we study the extent, then it is from the anteriorly, the eustachian tube opening till the funiculus, because above the funiculus will be the retrotympanum. So this is the part which is referred to as a hypotympanum, and it has a medial limit of the carotid canal, and posteriorly it is limited to the styloid eminence and the facial canal, the vertical segment of the facial canal. And there are specific cells in the hypotympanum which can give us various approaches for the disease clearance, like hypotympanic ear cells. Since this portion, the inferior portion, is formed by the petrous part as well as the tympanic part. So if we drill carefully in this area, preventing the medial aspect, anterior medial carotid canal aspect, and the inferior jugular bulb aspect, we can clear the disease from till the petrous apex through hypotympanotomy, an infracochlear hypotympanic approach through the hypotympanic ear cells can be gained by accessing these hypotympanic ear cells. Another important ear cells in the hypotympanum are the retrofacial cells. So as I told, there is a relation posteriorly to the styloid complex and the facial nerve. So sometimes a pneumatization of the mastoid antrum continues in a retrofacial direction towards the hypotympanum. So we can access the hypotympanum through the retrofacial direction also, in case we are not able to clear the disease or any pathology in the hypotympanum. So this was all about the spaces around the compartments around the mesotympanum. Let's study the central compartment, or the most biggest compartment, that is the mesotympanum. And it is having all communication, as I said, but except the attic only through the tympanic isthmus. So the pouches which are very commonly seen in the mesotympanum and which is responsible for the ventilation of the mesotympanum are the two pouches, the anterior and the posterior pouch of von Trosch, anteriorly being between the anterior malleal fold and the pars tensa attachment from the anterior spine to the malleus handle, and the pars tensa part attaching from the malleus handle and the posterior spine in between the posterior malleal fold will be the posterior pouch of von Trosch. So this mesotympanum as a whole is ventilated from the eustachian tube, directly from the eustachian tube, but the anterior pouch of von Trosch will not communicate superior to the attic, not even the lower unit or the upper unit, but the posterior pouch of von Trosch is having communication to the PRUSSAK'S space, and it is responsible for the ventilation of the PRUSSAK'S space. But further, we know the PRUSSAK'S space will not ventilate any other part of the upper unit of the attic, because there is a diaphragm. So medially, we can see the medial part, as we studied in the medial attic, will be having the openings, the isthmus, that will contribute to the ventilation of the upper unit of the attic. So the last very important component of the endoscopic anatomy of the middle ear will be the facial nerve. So I'll discuss all the parts of the facial nerve which is seen in the middle ear. So first, the geniculate ganglion. The geniculate ganglion, it is the lateral limb. I am showing this picture of the left ear after removing the ossicular chain, only the stapes superstructure you can see, and this is the geniculate ganglion area which is present behind the cog bone, and it is the lateral limit of the labyrinthine segment of the facial nerve, and it is very well appreciated, or the landmark which is used for this is the cochleoform process, as it is seen just superior and anterior to the cochleoform process. So we can, and this cochleoform process is considered as a significantly resistant structure for most of the middle ear pathologies. So once we access this cochleoform process, we can see the geniculate ganglion and clear the disease or whatever pathology we are dealing with. But sometimes, as this geniculate ganglion isn't directly contact with the anterior epitympanum, they will be covering of cells above it. So we have to drill out some cells and expose this area to access the geniculate ganglion part. And sometimes this around 15-20% of the cases, the bony covering is dehiscent on the anterior superior part of the petrous bone, if we see from the middle cranial fossa approach. So one has to be careful about the dehiscence, rare dehiscence, percentage of dehiscence, which is common in the geniculate ganglion area. So this is all about geniculate ganglion and the landmark being the cochleaform process. Let's discuss another part, that is the continuation from the geniculate ganglion, the tympanic segment of the facial nerve. It is extending from the geniculate, it is present in the medial wall of the middle ear and extending obliquely in an inferior direction and posterior direction. And it is related to the cochleaform process, very almost around 1 to 2 mm of distance. A most important, a constant landmark for the tympanic segment is also cochleaform process, and it is present above the oval window and inferior to the lateral semicircular canal. So this is how we can identify the landmarks for the tympanic segment of the facial nerve during an endoscopic approach. Another, the second GENU, where the tympanic segment takes a turn and becomes a vertical segment, is also can be appreciated in an endoscopic approach. And we have to see the landmarks, that is the oval window approximately superiorly or posteriorly 3 to 4 mm will be the second GENU of the facial nerve, and the pyramidal eminence is considered as a very important landmark. Posteriorly and laterally to it will be the second GENU, and inferior to the lateral semicircular canal. And if we are seeing from the mastoid side, we can consider the short process of incus also. The medial to the short process of incus will be the second GENU of the facial nerve. And the last, part of the facial nerve which is present is the chorda tempori. It's seen as emerging from the caudal eminence and going towards the, in between the malleus and the incus handle, incus and the handle of the malleus, around the neck of the malleus, and it goes anteriorly towards the petrotympanic fissure in the canal of Fugger, and then it joins with the lingual nerve there. So this was all about the nerves. So I would like to conclude my presentation here by stating or summarizing my presentation by saying that a good knowledge of anatomical spaces and the recesses of the middle ear, along with the aid of endoscope whenever required, can lead to better outcome of any middle ear surgery, and we can reduce the risk of residual diseases as well. These are my references. Thank you.
Endoscopic
Thank you very much, Vasudha. Wonderful lecture. But there's only one query. That's
Yes,
on funiculus. Can you go back and show the funiculus again and explain?
Yes, sir. Yes.
And also sinus subtympanicus. Yeah.
Okay, sir. 1 minute, sir. Okay, sir.
Yeah.
I'll show this picture, sir. See, this is retrotympanum, sir. Retrotympanum is divided into two parts, superior and the inferior, by subiculum, a bony ridge.
Sir. Yes.
So the part of the retrotympanum which is below the subiculum is considered as the sinus subtympanicus.
Yes, right.
And it is bounded superiorly by subiculum, inferiorly by funiculus, anteriorly by the round window niche, and posteriorly by the styloid process. The retrotympanum inferior extent we have considered as a bony ridge, the funiculus. And this bony ridge, it is arising from the anterior lip or anterior pillar of the round window towards the retrotympanum, and it separates the retrotympanum from the hypotympanum. Let's see in the endoscopic picture. So this is the endoscopic picture of the left middle ear, and this is the funiculus. It separates hypotympanum from the retrotympanum.
Okay.
And fustus is nothing but a bony bridge which we can see in the floor of the face, round window niche, or we can see in the floor of the sinus subtympanicus. Its significance is not known, but it's just described as a term in the inferior retrotympanum, sir.
Yeah. Okay. Yeah. Thank you very much. Any more queries, friends? Yeah. Landmark for round window.
Sir, landmark for round window, it is said that the two bony ridges, that is the subiculum and the funiculus,
Yeah.
they form the superior and the inferior limit of
Okay.
this round window niche, sir, in the
Mhm.
inferior retrotympanum area. That's
Okay,
what.
ma'am. Yeah, that's right. Yeah, funiculus and fustis both are bony landmarks. Yeah, that's an observation. Yes. Any more question, friends? Endoscopic picture of petrous apex
So
is
that
difficult. Yeah,
approach, yeah, so that picture even I didn't got, sir.
yeah,
That is a
yeah.
different chapter, sir. I'll try to find it out if possible, sir.
Okay. So we will try to get that during next classes. Okay, we'll
Okay, sir.
do that. Okay, friends. Again, thank you very much. Look forward to see you again in the evening for our evening program, that is Weekend with a Maestro. We have postponed our radiology class mainly because of some issue with the Zoom. I am unable to extend or buy a large subscription because of some Reserve Bank of India and credit card issues. I think I should be able to sort it out by next week. Thank you very much. See you again in the evening. Thank you all. Thank you very much, Dr. Vasudha. Wonderful
Thank you, sir.
presentation. Yeah.